Good evening, Facebook Live, and welcome to the second webinar in now our fifth season of Endo Summit Live. This evening, we are talking about the international impact of endometriosis and pelvic pain, and we have a very, very exciting and interesting panel. We're going to have our panelists introduce themselves. We're going to start down there in my right-hand corner at 2 a.m. in her home country. Please welcome Olivia. Olivia, can you introduce yourself?
Thank you, Sally. Good morning, everyone. My name is Olivia Wakudu. I'm reaching you from Lagos, Nigeria. Here I manage a nonprofit called Endo Survivors International Foundation, which I founded 5 years ago, inspired by my own experiences with endometriosis. So Endo Survivors is focused on raising awareness about endometriosis through education, research, advocacy, and we have a thriving support group for women living with endometriosis in Nigeria. So much of our work revolves around educating adolescent girls about period pain, menstrual well-being, the symptoms of endometriosis, what their period should look and feel like, in a bid to encourage a treatment-seeking behavior among young girls who are already having some symptoms. Because we all know that it takes an average of 7 years to get diagnosed with endometriosis. And bulk of the reason for that is that young girls don't even know when they should go to the hospitals to present with pain. So something very dear to me is educating young girls about the symptoms. And in addition to that, we do conferences and a whole lot of advocacy programs about endometriosis in Nigeria. So it's good to be here. It's good to meet every one of you. And I look forward to a very interesting deliberation with all of you. Thank you.
We are so excited to have you towards my lower left side. It's funny, I feel like the Brady Bunch all the time with we have Dr. Allison Shrikandi. Dr. Shrikandi, do you want to introduce yourself and talk a little bit about what you do?
Sure. Thanks for having me, Sally. Wonderful to meet you all. I am Dr. Allison Shrikandi. I am the co-founder and chief medical officer of Pelvic Rehabilitation Medicine, and we take care of women with chronic pelvic pain. And around 70 to 75% of our female population does have endometriosis at Pelvic Rehabilitation Medicine. So really on the front lines of endo, we are a national healthcare company in the U.S., from New York to LA, with clinics serving patients with endometriosis, really with a comprehensive approach to endo, working with endometriosis excisions, the surgeons, as well as non-operative pelvic pain specialists with office-based procedures. And then also we have integrative nutrition and behavioral health. So that comprehensive, holistic approach to treating endometriosis.
It's awesome to have you here. Now, also joining me from Canada is Amanda Frushi. Amanda, can you introduce yourself?
Yeah, I'm Amanda. I'm from Canada, as Sally mentioned, and I am a patient with endometriosis. I just received care where I had to leave Canada and received excellent care from Dr. Vidali in New Jersey. I'm 6 months post-op, and I'm really happy to be here and share my experience, one that I'm sure many people in Canada definitely can relate to.
It's wonderful to have your voice here with us tonight. And joining us, last but not least, is Alex from Invisible Iconic. Alex, can you share a little bit about yourself and your organization?
Yes, thank you so much for having me here, Sally. I'm very, very excited, very honored to be here. Most recently, Invisible Iconic became a small business, and I run educational workshops about endometriosis. So it is an endo education business, but overall I've been an endometriosis advocate, and more importantly, a patient, an endometriosis patient. I can say on the front lines, and my voice gets shaky because I was the second person in Australia to have pelvic sidewall and sciatic endometriosis, a laparoscopy. And so I very much felt like a guinea pig, and there's a lot to be said about my personal experience, but in terms of what Invisible Iconic does, I am the creator and host of the Invisible Iconic podcast. We also have educational webinars, and we run locally endo circles, but we're hoping to expand these educational support groups, hopefully to Sydney and Newcastle soon. And eventually we have, I say we, but I, as the sole person working here, and then all the lovely people that are joining on the webinars and endo circles, we're hoping to expand at some point nationwide. So I'm very happy to be here. Thanks for having me.
Wonderful. Now, Olivia, we'll come back to you. I wonder, what was your journey like? How were you diagnosed with endometriosis, or what was your diagnosis story?
Yes, so I always had severe menstrual cramps, as a young girl in secondary school. So I started menstruating maybe in my senior high school, but it wasn't regular until I finished secondary school. Then it was regular in university. So that's when I really started having severe pains. I think I was about 17 or 18 at the time. So of course, my mom didn't know anything about endometriosis, and nobody thought much about it. We just felt it'll go, but it did not go. So it got worse over time. And one time, I think I was 20, maybe 22, when I started having this severe pain on my lower abdomen, on my right. So we went to the hospital, and the doctor thought it was an appendicitis. So they had to remove my appendix. And the pain did not go. The pain continued. And it was after that, someone advised my mom to take me to a bigger hospital, a government hospital here in Lagos. And I went there, and that was the first time I would see a gynecologist in my life. That was at about 23. So I had to do another scan. He asked me to do a pelvic scan. And when the result came back, he said I had a big ovarian cyst on my right. So the ovarian cyst was responsible for the pain all these years. And we had an appendectomy, thinking it was the appendix. So after I had removed the appendix, the pain did not abate. I then saw this gynecologist who said it was ovarian cyst. He placed me on a drug, one of these hormonal tablets, to just take for a while, which I did. The pain, was manageable at the time, but I kept having the breakthrough bleeding. And shortly after, he advised me to stop and start again. So when I stopped taking the hormonal tablet, I then observed that I had this little swelling on my umbilicus. So when the gynecologist saw that with my symptoms and the ovarian cyst, he just diagnosed the endometriosis. So I hadn't done a laparoscopy. I hadn't done any of the techie things, but based on my clinical history and my presentation, and because laparoscopy is not so accessible here in Nigeria, and when it is, it's quite expensive. So he just made a judgment call because he thought it was unnecessary for me to have that expensive procedure just to get diagnosed. He just diagnosed me, and I started taking the pills again. And he said I was going to have a surgery. But the pain continued, even with the hormonal pills. It was so bad. At the same time, I had fibroids. So my parents took me to another clinic to remove, the fibroids. And it was during the myomectomy, I then got a definitive diagnosis for endometriosis, because tissue was taken from the umbilicus and of course from my pelvic area. And that was how the histology report came back as endometriosis. Of course, we already knew what it was, but now it was confirmed. And I've been on a roller coaster journey with treatments, surgery, hormonal pills. I've tried every other thing, just just trying to manage my health and live a productive life. So that's my story in a nutshell.
Thank you for sharing. What a journey. Is that typical in your country that many will not be able to access surgery?
Oh, yes, it is. Laparoscopies are very expensive. Because, okay, here in Nigeria, just like in the US, we have private healthcare and we have the public funded one. So the government hospitals, of course, long waiting times and all of the hitches that come with that, even though we do have very good specialists there, but a lot of times patients may not want to go to government hospitals for, obvious reasons. And when you do go to private, the private clinics are really expensive. So the average person might not be able to pay for a laparoscopy, except maybe with health insurance, or if the person just manages to have, some money. But it's not something you just have access to. There are not even very many that offer the service. And when you find the ones who do offer the service, it's quite expensive. So a lot of us here get diagnosed clinically, and that's why as a nonprofit, we do champion non-invasive procedures for diagnosis. We advocate for the need, for non-invasive procedures, because apart from the cost of getting these invasive procedures for diagnosis, we do have a lot of culturally conservative people and religiously conservative people who may not want to have a surgery just because they want to get diagnosed with a disease, if you get what I mean. Even for treatment of disease, some people are afraid of going under the anesthesia. So they wouldn't do that if it's not necessary. So there are lots of women with endometriosis who are not even diagnosed, and there are lots of women with endometriosis who have been diagnosed, but they haven't had a laparoscopy done, and they are being treated for endometriosis, you see. So it's quite a bit tricky. So as a nonprofit, we do champion the need for non-invasive procedures for diagnosing endometriosis, and we always applaud, any available means like imaging or any other way to get women diagnosed without necessarily going in, because I do know there are pros and cons to that. But a lot of times when people are suspected to have endometriosis, they do have endometriosis. And if we do not take that into account, the diagnostic delays will keep extending, because a lot of people think that endometriosis is rare in Africa. And that is one of the reasons, because the skill and the availability for diagnosis may not be readily there. They may not be readily available. So because you're not diagnosing them, you think the disease is not there, but it's there. The symptoms are there, the presentations are there, but we can't just keep waiting for a laparoscopy before we get treatment. So sometimes doctors have to make that judgment call and just, make this diagnosis clinically based on what you're presenting with, and then your history. And then they put you under necessary treatment. And if the hormonal, the hormonal interventions are not giving the results that you need, then you have a surgery. And a lot of times when they do have the surgery and the histology report comes back, it's endometriosis.
Yeah, it's very interesting. This is why we're doing a big pelvic mapping training, both on ultrasound and on MRI. And I think we already have a lot of flack, like how dare we do those kinds of trainings, because it'll lead to like people getting ultrasounds instead of getting diagnosis. But I think what most don't realize is not everybody can access that. And so it brings me to my next question, because I think there are countries where they misuse the technology also. Amanda, do you want to share what was your experience having endometriosis in Canada?
I mean, it was a horrible experience having endometriosis, and I think being in Canada made it extra awful. I was, and I have to admit that my journey from like diagnosis to like where I'm at now post surgery is actually quite short compared to what I know so many people go through. looking back on my history, my health history, I can say that for certain I've presented symptoms of endometriosis my whole life, but not because of painful menstruation. I had more bowel symptoms and stomach stuff. But in 2022, similar to Olivia, I had a pain on my left side that was very different than what a usual menstrual pain would be. And like I did have cramps typically, but this was something that had me very worried that it could be a kidney thing. Was taken to ER by ambulance, and they found a large cyst. Well, actually, at the time, it was only about 4 centimeters in size. And then month after month from there, I was in the ER every month, and the cyst was growing exponentially to the point where it had reached 7 centimeters within a matter of a month and a half. So I had an OBGYN through rapid access gynecology clinic, because getting a gynecologist here to see you was very hard. I couldn't get anybody to take a referral and see me within a period of time less than 12 months. So because my symptoms were so persistent and the cyst was growing so rapidly, I got through a rapid access clinic, is what it was called, through one of the hospitals, and was booked into surgery within about a month's time, removed the cyst, which was endometrioma, so they could diagnose the disease. But unfortunately, the gynecologist who removed the cyst tried to separate the organs that had been fused together by disease without the skill of excision surgery or any skill whatsoever, really, to deal with endo. So when she tried to, what she described as pull my bowels away from my uterus, I guess the disease just spread because I was in severe pain after that surgery, and was trying to get an excision specialist and here to see me. I'm still on wait lists of about 12 months now. I'm 6 months post-op and I'm still on wait lists here in Canada.
It's interesting because we were talking to a Canadian doctor who's fairly decent at AAGL. And he said to me that by the time patients get referred to him, sometimes it's 18 months or more. Mm-hmm. And then he's a specialist who needs a lot of other imaging and scans because he does a lot of nerve work. And he said, then it could be 18 more months for them to finish getting the MRIs that he needs. So he said a minimum of 3 years from getting referral until surgery. And he kind of like, this guy, I know Alex can share what like nerve endo is like, who kind of just threw up his hands and he's like, I don't know what to do anymore. Alex, what is the experience of having endometriosis like in Australia?
So, Sally, I can speak from my experience, and I have to preface that by saying, according to the inventor of neuropelviology, Professor Mark Possover, he thinks I have an atypical case of sciatic endometriosis. So when I'm talking about nerve endo, perhaps my experience is atypical, even if it's only in presentation. But when it comes to everything else, I think a lot of people with bowel endo, this is from the experiences of a lot of people I speak to. I've been in this space for at least 7 years since I've been actively not only battling the disease, both pelvic presentations, but more importantly, extrapelvic. And when I say more importantly, it's because in Australia, we're really not seen. A lot of people with bowel endo are told it's just IBS. Although I support particularly innovative technologies in terms of imaging, you know, I'm interested. I'm not a Luddite. I'm interested in AI. I'm interested in all these sorts of things. But unfortunately, my disease, after 3 laparoscopies, 2 of which were with top experts in Australia, people who were equipped to deal with extrapelvic disease, who had at least heard of it, treated it, etc. My experience after 3 laparoscopies was that I had to fly overseas, not only for consultations in Switzerland, in Romania, with people. Professor Marcos is a neuropelviologist, but I also went to Romania. I had a deep infiltrating endometriosis MRI. This was 2 months post-surgery in Australia with the only person who is trained in neuropelviology in Australia. So when we're talking about neuropelviology, we're talking about the nerves in the pelvis. Unfortunately, gynecology is the primary field where we hear about endometriosis. And as much as, yes, we have fibroids, we have cysts, we have, more encountered, but certainly difficult presentations like endometriomas, you have more atypical presentations, and the nerve endo sometimes comes and often comes with bowel endo, which in Australia we're being told by our national organizations, which, although I applaud, there being $87 million going towards endometriosis over the next 4 years. And I'm sure other countries are hearing me and are detecting a tone, and yes, I applaud $87 million going towards endo. I applaud the word even being uttered, and politicians wanting to put money where their mouth is. But unfortunately, $0 is going towards excision training. In Australia, your average gynecologist, in fact, the Australian Gynecological Endoscopic Society, they only require 10 surgeries be performed before gynecologists can ablate or excise other parts of, our bodies, bowel, etc. And in my own experience, when I went back to Romania and had that MRI after 3 surgeries in Australia, I still have disease all over the place, including sciatic endometriosis. So, for me, the path to diagnosis, having access to healthcare, private healthcare, being privileged, I got there, but am I still suffering 100%? I still have thoracic presentations, sciatic presentations, bowel presentations that haven't been adequately treated in this country, despite having access to all the things that help in terms of pain management, in terms of physiotherapy. I have had access to all that, but unfortunately, not only is my experience of endometriosis atypical in terms of the presentation and the sciatic stuff, I've also had a horrible experience in terms of hormonal management. And although, yes, not everybody has access to laparoscopy, and it's the same in Australia, we have people in rural areas that struggle to get there. And if they do, they're just getting ablation, and it's not really enough. And I could go on another tangent, but I won't. So it's very difficult.
Right. Dr. Shrikandi, you see, and also you've been at it. You guys who don't know, Dr. Shrikandi and I have been at this together for at least 10 years and trying to really teach that your pain may not be solved by excision alone, that there is a lot involved in healing, but B, that you don't need to crumble on the burden of gaslighting. So can you share a little bit of what you're seeing in the trenches in the United States from treating endometriosis?
Sure. I mean, honestly, Amanda, Olivia, Alexandra, your stories are what we do hear, all day, every day, unfortunately. The delay in diagnosis, I think over the past decade, Sally, I think it has improved. I think we are starting to get patients earlier, but it still surprises me on the amount of patients that we have that have been suffering even for 10 to 15 years plus, even longer. So it is a classic story where, you multiple things where there's some sort of, cyst that was blamed on a ruptured cyst, your pelvic pain. Is very common to hear, or very common where you see in our patients' past medical history of, they had an appendectomy for, consideration of potential appendicitis with that right lower quadrant pain. Those are all very classic in what we hear and from our patients' journey and our patients' stories. So even in 2023, we are continuously astounded by really the delay in diagnosis. And, again, it is these classic symptoms that when you're in the world of endo and you're in the world of pelvic pain seem very obvious to us. But I think it's really that deeper rooted nature of really getting to the medical school and the residencies is, I think, the key, so that it then, as those providers and those trainees graduate, it's ingrained in them from day one, rather than trying to reteach a thought process that wasn't really spoken about early on in their education. But yes, that would be the classic patient symptoms that were the ultrasound was normal, MRI quite often is normal, right? Blood work, no infection for their burning. And, seeing multiple providers. We did write a paper at Pelvic Rehabilitation Medicine, Amanda, where trying to get gynecologists, OBGYNs, and GIs to collaborate and get gastroenterologists to think of endo, because of that, the young females who are diagnosed with IBS so often, but to try to encourage them to think of endometriosis. So, just educating the gastroenterologists as well and collaborating with the gyns. So these are all, I thank you all for sharing your stories. It's amazing to hear from all of you, your individual journeys, and what's going on in everyone's unique countries.
I have so many questions for everybody, but I'm gonna start here. Olivia, in Nigeria, is endometriosis taken seriously as a pain and quality of life disease, or is a lot of its weight put on that it's a reproductive disorder?
Yeah, thank you for that question, Sally. So as it is now, I would say there's really little awareness about it. So most of the time it's taken as an infertility problem. So because we are in Africa and fertility is actually a big deal, so that's the reason why they would take endometriosis seriously, not so much about the pain and the quality of life or the loss of productivity side of things. Because I find that a lot of the healthcare providers, they think that with endometriosis, we'll just give you a pill, you take this, you'll be fine. So sometimes they get really baffled when you keep coming back and you're complaining and the pain is not going away. And you hear things like, oh, this person is unable to walk, she's unable to go to work, she's unable to do so many things. I find many of them are confused and they're wondering why does it have to be that way? But there are those, of course, among them who still do understand that endometriosis is a quality of life thing, but that knowledge is not widespread at all. It's something that there really needs to be a lot of awareness, around. But for the infertility side, yes, they take it seriously because in Africa, in Nigeria, it's a big deal. Everybody wants, the daughter or the daughter-in-law to have a child, especially if you're married. It's something they prioritize. So, and I don't know if you know this, but we do have a lot of fertility clinics in Nigeria. I like to think of Nigeria as the IVF capital of the world. So it's more around fertility than pain and
I do know that. That's why I asked you the
you
question.
do know.
I think it's interesting, the term that you used, everybody wants the daughter-in-law to have the child, because first of all, not the first time I heard that. But look at the way, like, that's the value still of women, is that they're supposed to be producing I see Amanda rolling her eyes. You want to comment?
Well, I mean, like when I had I'm on like my 5th general practitioner at this point, family doctor, because there's like nobody cares. And that I've had my 2 kids. I mean, his GP 5 GPs ago, like the guy that I was with when I first presented symptoms was like, well, are you done having your kids? Because if you're done, then we'll just do a hysterectomy.
Wow.
Like, just like that, like no big deal. Are you done having kids? Which, Yes, I was. And did I end up going hysterectomy with Dr. Vidali? Yes, I did. But the fact that like endometriosis didn't even come out of his mouth as like something that we could be dealing with. It was more like, oh, well, but you're in pain. You don't want to be in pain anymore. Let's just remove the uterus. You don't need it anymore.
Yeah, let's ask the pelvic pain specialist for a second something. I am sure that you see people post hysterectomy who were told that was going to cure their pain. What might a hysterectomy help with, but really what doesn't it help with? Because I could list as the PT 78 things right now. I could list them all.
Yeah, so a hysterectomy is curative if you have adenomyosis, right? Which is where the endometrial-like cells are in the wall of the uterus itself, right? However, the definition, right, of endometriosis is endometrial-like cells are found outside of the uterus. So therefore, a hysterectomy would not be kind of curative for endo. It would be curative for adeno, and I think that that's quite often confused. And sometimes they do sometimes come together, right? They can also be the evil twins, but I think that it's important to know that it's not curative when you have a hysterectomy. And it's very common where patients are, oh no, I had a hysterectomy, I was cured.
I feel like the hysterectomy doesn't do anything for the disease. It doesn't do anything for the pelvic floor. It doesn't do anything for the bladder. It doesn't do anything for the nerves. It doesn't do anything for certainly the microbiome. And and people think it's this definitive treatment. And then we get angry because it didn't help at all, which brings me to, Alex, in Australia, and also in Canada, you guys have a much different relationship with the term central sensitization. And so for those of you that don't know, central sensitization is it's a proven concept that the brain continues to recognize the pain even after the disease has been removed because the system is upregulated. I think we have a whole night actually with Dr. Ahmed where we talk about that. But I see when I talk to my international friends, oftentimes this term, which is a real thing, is being used as a weapon to minimize your experience. Alex, do you want to share anything about that? I see Amanda nodding. I even see Olivia nodding.
I'll try not to rant, but I have seen 7 pain specialists in my time, and they are the only person who should be diagnosing you with central sensitization. However, there are a couple of instruments that pain specialists should be using when giving you that diagnosis. And there is a questionnaire, but there's other different tests though. There's actual physical tests that they can do. I don't doubt that after 3 surgeries, I have central sensitization, particularly when I've had nerve involvement, etc. However, as Sally has already said, it's certainly used as a modern word for hysteria. I'm just going to put it, as it is. And many of my friends have had exactly the same experience. Now, do we have central sensitization? Probably. Do we also have extrapelvic endo that hasn't even been, when you're having a transvaginal ultrasound, even if it's the best imaging, even if you're going to get AI to read it, if you're only looking at that organ and reproductive structures, you're not seeing my sciatic endo. You're certainly not seeing my diaphragmatic and suspected thoracic endo. So we don't have the imaging, and if we do, we don't have the people to interpret it. It's interpreted as pleural effusions, subcutaneous emphysema, etc., instead of pneumothorax. So, yeah.
Go ahead. Amanda, I didn't ask, what province of Canada are you in?
I'm in Ontario.
Oh, so I see it more in our British Columbian Canadian friends, but speaking for all of Canada, since that's your role right now, what has been your experience with this term central sensitization?
I've never heard it before.
Oh, okay. So I'm going to share a little bit that there is some literature being produced in BC And then all the patients that end up at that clinic, instead of having their endometriosis treated, only have this one component of endometriosis treated. And it becomes frustrating for two ways. It's horrendous for the patient because it's very minimizing, but it's also horrendous for the educator who's trying to explain that this very much exists, because now patients have been burned by its existence. Dr. Shrikandi, what is the right way to approach central sensitization? You know, what is the right way to talk about it with not how to treat it, but what is a good way to talk and educate a patient about it?
Sure. Yeah. I mean, conceptually, central sensitization would be, we describe it as if there's upregulation of your central nervous system, right? We describe it almost as if it has ADHD. Things are firing inappropriately. There's a combination of things that do happen, but it is real changes that do happen at the mRNA level from when endometriosis, that pro-inflammatory state, from the peripheral nervous system through the spinal cord to the brain. So that neurogenic inflammatory process upregulates your central nervous system, and things such as increased synaptic recruitment happen. Loss of that descending inhibition that's supposed to happen is lost, and your nerves start to fire too soon. And when they do fire, there's an increase in their firing. And that all leads to central sensitization. And conceptually, it does mean that things that technically may not classically cause pain, such as touching you with a cotton swab in the area, may cause pain when you have this sensitization process. And overall, it really is looked at more of as the part of the complex of endometriosis and pelvic pain. That's how I would describe it.
Excellent. We have I was checking the questions from around our platform. Olivia, we have a question. How would you get an OB to listen to you about endometriosis? So you're going out in the field with the Endo Survivors Network. How do you teach people to speak to their doctors to maybe get taken more seriously?
Yeah. So we just tell them to explain how they feel. But first of all, if we were to talk to the younger girls, to the school girls, we teach them to track their periods. So we do have this material that we distribute to them to, just to educate them on how a cycle looks. So some people will have a cycle of about 22 days up to 32 or 33. Which is like the highest. You shouldn't exceed that. So you should know how your cycle should work and what your period should look like, so you can even know what to say. Because when you do go and see an OBGYN, those are the first questions they will ask. When was your first period? Has it been regular? Did you feel pain? What kind of pain? Did you take a drug? So we teach the young girls to know that. Then for the older women in the support group, we just encourage them to advocate for themselves. Our doctors here are quite kind and very relatable, to be honest. So you don't really have to do too much to get the doctor to listen to you, provided you can say what you feel. So you don't go to the doctor's office and try to make your symptoms look like they are nothing. Because if you go and make it look like it's nothing, they are not in a position to make it look like something, right? So you have to say the symptoms you're experiencing, how it feels. You should be able to describe the pain, how current or how frequently it comes. If it's a cyclical pain, you should be able to say, oh, it starts on day 1 of my period or day 2 of my period, and this is how intense it is, or this is the location. So when you're able to describe your pain, the intensity, the location of the pain, the cyclical nature, of course, your doctor will be able to make an informed recommendation for you.
So we hope. I think that's amazing that you have that that all put together for people within Endo Survivors Network. I think it's something people should contact you to discuss. Alex, I wonder what kind of advice do you have people for talking to a gastroenterologist or GI specialist?
Yeah, so the last gastroenterologist I saw told me that he had only heard of one case of bowel endometriosis. And obviously I was sent for the usual markup of colonoscopy, endoscopy, which obviously didn't show anything because in only 1 to, I think 3%, but more on the 1%, 2% side of bowel endometriosis is actually seen in colonoscopy. And yeah, in my experience, they don't know much about it. If they do, if you're lucky enough to have them working with a excision surgeon, so if you have a bowel surgeon, for example, as part of your laparoscopy, oftentimes they'll just do bowel shaving. They will think that a discoid resection, anything like that will be too risky when the patient will, may need it. So we don't necessarily have the training when it comes to the surgical side. And in terms of the detection of the disease through, seeing a gastroenterologist, and even with things like a gastric emptying study that I had, for example, these things are not seen. The way we're trying to diagnose it is through, I'm not going to say archaic, but it's not showing up disease a lot of the time, and if it's not a lot of the time, it's enough of the time that I'm hearing about it with only a few followers, so it's not as rare. Extrapelvic is certainly not rare, and it's, not being seen.
It's interesting because I see actually an obesity doctor for my thyroid, and in the middle of the appointment, I'm like, I say to him, I can't take, he's a genius with the thyroid, but it still doesn't understand I was infertile, not just because of the endometriosis, but because the Hashimoto's, right? And I said something about SIBO and endometriosis, and that I will pretty much have SIBO. I might not have active SIBO the rest of my life, but I will almost always have it because there's adhesions present. And he says, and he knows he shouldn't say this, but he says it anyway. He says to me, wait, you had a hysterectomy. Like, why would you still have, which I didn't have a hysterectomy, but you're postmenopausal. Why would you still have endometriosis? Like, they don't get it's, and you're saying it to me, who's sat in your office and done webinar and done, it's like banging your head against the wall sometimes with the GIs. I think when you find a good one, you really have to work hard. I have a question, Dr. Shrikandi. I don't know where you are in the process, so that isn't that. But I know that at one point you went to talk to one of the states with Blue Cross Blue Shield, and you tried to explain to them that patients had pelvic pain, and they were like dumbfounded that this happened. You've shared that story with me before, but can you share it with the rest of us? You don't have to share like nitty gritty you're not ready to talk about, but the story itself is very interesting because it gets at, we're still not valued as patients in some ways yet.
Yeah, no, it is interesting. Yes, having it was over dinner with the former president of one of the larger Blue Cross Blue Shields in the country, if not, I think the largest, and just discussing chronic pelvic pain syndrome and endometriosis, and just a lack of understanding of endometriosis, the disease process, really, and that chronic pelvic pain syndrome. The comorbidities that correlate with it, right? Bladder pain syndrome, IC, adeno, PCOS, and the psychological aspect, just not understanding the whole disease process at all, not understanding the diagnostics, the treatment options, but just really not even realizing that it's a real patient population that they should be concerned about. So it was really eye-opening for me that, wow, it is, it's a bit challenging. We're really defining the disease process right now, I think, in America, for the healthcare system, that it does exist, it is real, and this is kind of the, how it works, and these are the morbidities, and these are the, diagnostics and treatment options we have. So it's really just starting with the ABCs, starting simple and then building, and these are high level, and this this person I was speaking with was a physician. He was an MD. So he wasn't, so he had medical training as well. So yeah, that's where we stand, and we'll get there, but it's going to take knowing who, you can't really have a discussion if you don't realize where the other side is coming from.
Yeah, I've heard the story at length, and I was, so one of Dr. Shikandi's responses was she now has been collecting data, I think, for the past 8 years, right? And so it's in the US, this matters a lot, independent data source, right? It's not a pharmaceutical sponsored data source. So that goes a long way. We are going to discuss that data at the summit, so we're not going to do it now. I wonder, those that have traveled for care, Amanda, what was that process like, in particular, when you needed a follow-up doctor local to you in Canada?
The process itself was actually kind of scary, right? Like to think that I have to leave my country and the place where I feel comfortable being, with this universal health care that's supposed to be so great here in Canada. So I wasn't comfortable. Luckily, Dr. Vidali is incredible and made me feel okay with my decision, but it was scary. And I also didn't have the support from the medical community here that I needed, like to make me feel like I was making a good choice. In fact, now coming back, it's kind of like you get this sense from doctors that they don't want to touch you with a 10-foot pole because they didn't do the work, they didn't do the surgery. That's what, they don't, and we still have the gap where the healthcare providers here don't have, like Dr. Shikandi was saying, the language, the knowledge to even so when I go into a new doctor now and say, I have endometriosis, they still don't even know, or we're not using that word. So not only do they not want to touch it because they don't have the basic knowledge, but then I say I've gotten treatment out of country by a different surgeon, and they're like, well, I can't help you with that then, because he did the job, or it wasn't done here, or maybe that's not the way I would have done it. It's kind of like you're out on a limb. It's kind of like you're out there on your own, and it's I'm building a team of care for myself that includes my PT, that includes a new GP, that includes naturopath or whoever I can kind of gather into my little circle to make me feel like I'm being cared for. But it's still a me job. It's not. It's all on me to make sure that I am finding those people. Nobody can help me, is what it feels like. It's very lonely.
Thank you for sharing. Alex, I have seen Australians shamed by national organizations for traveling for care. What is that stigma about in your country? Why do we attack American clinics that have only done right by the patients as national organizations? I mean, just comment about the stigma of traveling for care.
Firstly, like Amanda, I also traveled for care. For me, it was only the imaging because I've had all my surgeries in Australia. But after coming back with that imaging, I had pretty much the same experience. I went back to the same surgeon who was just like, and wouldn't give me my 5 hours video of the surgery. In terms of why is traveling overseas, particularly for excision surgery for interdisciplinary excision, laparoscopy, why are both patients who are promoting that, seeking that, as well as, international organizations being met with this, ferocious attack? That's really all I can say. Is complicated, and there's many different reasons, but what I could say is all around the world, our first line and second line tier treatments are based on pharmaceutical interventions and hormonal contraception primarily, which underpinning that is the theory of retrograde menstruation. That speaks volumes. And if I could have a megaphone, I wouldn't be shouting anti-pharma slogans. It's not about that. Although there has been a concerted effort to turn People who are advocating for excision surgery, and especially, to be trained properly that it is an extrapelvic disease, that, we are some sort of conspiracy theorists. We know excision works. We know that in terms of fertility outcomes, which 50% of us might be dealing with, but in terms of fertility outcomes, certainly having expert excision can help after it. In Australia, as well as in Nigeria, as I've learned today, fertility is the primary concern, which is why we have $87 million going towards everything but excision, $0 going towards excision. Our surgeons have to train themselves. The money isn't going towards that. So I think it speaks volumes that there's two different camps here. And, perhaps people think I'm being hyperbolic, but there's nothing exaggerated here. I myself have been a victim of these sorts of, defamatory campaigns. Just
Right.
for
I
experience.
There was literature released from Australia that anyone who is online fighting against this retrograde menstruation, fighting for excision, is vitriolic, right? To the point where I want t-shirts that say Team Vitriolic, right? They definitely put out this research from Australia that it was an opinion paper that basically we're all vitriolic and we should shut up. And what's interesting is we didn't shut up. And I didn't see a note that said it had been edited, but when you look at the copy of the document now, it's been removed. That whole comment about being vitriolic and such. And so I think, like, I've seen Canadians basically threatened for doing their work. I've seen organizations go from really well-meaning organizations to being funded by sources who are really going to profit by maintaining retrograde menstruation. And then you think about, these are in fairly big, large countries. In the smaller countries, people can't even get care. It's a crazy thing. Now, my friend Mariela Guzman from the Layla Foundation, who is helping me plan Endo Summit Spanish, which will happen March 8th, and will be available for free. She says that we don't often sit in a room and say, but what was sex like for you? Right? That's sort of a conversation we sweep under the rug. So while I have everybody here, I'm going to start by us not sweeping under the rug. So first of all, we're working on having a pajama party at the Endo Summit so we can have this conversation in a larger scale. But I would just, for those that want to talk about, I'll start. I did not know that sex wasn't supposed to be painful. And the first time I mentioned it to a medical professional, they told me to have wine before sex, right? And I was 23. I wasn't diagnosed until I was 34. So this was a lot of years. And I'll tell you, everyone I asked, they pretty much said the same thing. Does anybody want to share, like, how Mariella says it's time for us to break this barrier. Does anyone else want to share how endometriosis has changed physical intimacy?
I'll share if no one's brave. Yes, no, certainly, especially with that posterior cul-de-sac, pouch of Douglas, deep disease in your bowel, things like that. It certainly has impacted, my intimacy and, sexual function, to the point that even, and we're not just talking about penetration here. People might think, but there's things you can do, and hence, like in Sally's experience, have a glass of wine, which certainly doesn't help if even just tightening my pelvic floor externally without penetration can cause excruciating pain sometimes. And I'm talking about the type of pain that it's really hard to source where the pain is coming from. The general region, and it's hard to demonstrate on a live, you know the general region, but it is not being found during pelvic physiotherapy appointments necessarily. It's not being seen on imaging. And our expert surgeons, which, as I've said, only need to do 10 laparoscopies before they can play around and ablate or excise, are not seeing it. And then, expert MRIs overseas are seeing it and are validating us. And then we come back here and, it's back to the same. I've heard people from national organizations suggesting sex as a tool, as a pain management tool. I won't, mention the ages to which this pain management tool was recommended, but it doesn't work necessarily when, people are in excruciating pain, and it's hard to talk about. It's hard to express, it's traumatic. A lot of people have, if not neurodivergence, but also trauma related to, sexual trauma. This is a crisis. I'd like to call it a national crisis and an international crisis. And it's, whether you're suffering from pelvic or extrapelvic disease, certainly acknowledging the pelvic, psychosocial, spiritual aspect of what the pelvis actually is. And we're not just talking about, the womb and fertility. We're talking about and we're also not only talking about women. There is a case in Sydney in 2019 with endometriosis in a cis male in his prostate. We're talking about trans people, particularly female to male patients, having 1 in 4 have endometriosis. So there's, broader conversations needed to be had, but certainly sexual function is one that needs to be addressed.
Absolutely. Does anyone else want to share?
Well, it's like you, Sally, like I just didn't know that sex wasn't supposed to be painful for the longest time. And it was only recently after the surgery, excision and hysterectomy, where I went for follow-up care back here at home, and I mentioned to the OB, who I will never see again, when is it safe for me to have sex, or when can, and she just like the most offhanded, like, oh, you can have sex after 6 weeks and it'll be the best you've ever had in your life now that you've had the hysterectomy. And it was like, it was like a reminder of all of the pain that I've gone through for all of these years, not knowing that it was disease. And then it was very dismissive of my experience. And the truth of the matter is, since surgery, it's been a real journey to get back to intimacy without the pain and without that worry that I always carried with me. So it's like the impact of that lasts a really long time. And I don't know if it goes away. I mean, I have a wonderful partner. It's a supportive environment, but it's a very real, traumatic, unfortunately, experience for me. That's how I would describe it.
Thank you for sharing, both of you. Olivia, you don't have to. Would you like to share anything? Doesn't have to be about you in particular either.
Yeah, so generally speaking, endometriosis does have that impact on intimacy, and on not just intimacy, but even relationships generally, because you see the pain with sex has this effect on every other aspect of the relationship, so it's something that should be really looked into. There's hardly any research, or maybe because people don't feel comfortable talking about it, but there's hardly any research done on that, especially here in this part of the world. So I believe it's something we should talk more about and really look into.
I think if you only see us as baby makers, then understanding that we have a right to pleasure becomes even harder. Just throwing that out there.
Yep.
All right, so switching gears, the Endometriosis Summit is coming up March 8th through the 10th in Celebration, Florida, but virtually worldwide. We end every Endo Summit Live like this. I will start with you, Amanda. What are you looking forward to about the Endo Summit?
I think because again, my journey is kind of short in relation to what I think so many other women seeking diagnosis is. I feel like I got this crash course in endometriosis and how to manage pain and then how to find treatment and then the journey to recovery. So I think I'm really looking forward to being, someone who's diagnosed with the disease in a community of others who understand my experience, and maybe even gaining some insight into how to be a better advocate, I think is something I'm really interested in now that I'm at this stage post-op. I'd really like to take on that role in a bigger way for folks in Ontario and Canada and anywhere where I can be helpful. So I'm psyched to learn from all of you and really pack my toolkit.
Excellent. Alex, by the way, Alex is in Australia. For our Australian friends, the Endometriosis Summit is not only available virtually, but it's available recorded. So you're able to listen not at 3 o'clock in the morning. But Alex, what are you looking forward to most about the Endometriosis Summit?
The conversations around imaging. I mean, I sound like I've been quite critical, but I am interested in new technology, and I'm interested to see that imaging is not a complete diagnosis. So I'm interested, as always, to see the patient experience. Not only the pharmaceutical interests,
Well,
which
it's interesting because our lab head, the director of our lab, he trained many of the top imagers in Australia, and he says Australia's taken it and run with it. So it'll be interesting to see the full presentation for you to really find out if that's real or how that works. Olivia.
I'm very curious. It's not always support, but I'm eagerly anticipating and very curious. Yeah.
Yes. Olivia.
Yeah.
What are you looking forward to about the Endometriosis Summit, if at all?
Yeah, I'm looking forward to the imaging, scanning, non-invasive methods of, is it Dr. Matt? Who's the person coming? What's the name?
We have Dr. Di Giovanni
Okay.
for MRI. We have Dr. Abrao from Brazil, and we also will have Dr. Wasson and Dr. Young from the United States.
Yeah, okay.
That's on the main program. For medically licensed individuals in person, there's a 4-hour lab.
Wow.
Yeah, that I would love for there to be CME, and I've applied for it, but I don't know what'll happen with that. But that is a little different. What's going to be shown is on the main program, but there's 4 hours for the physicians, 4, maybe 5 hours, might be 5 hours. Anyway.
Great. Yeah, so I'll just look forward to that, and of course connecting with other patient advocates, doing great work, just learning new things and things that we can actually apply here to just raise more awareness, help more people, and get endometriosis to be on the top burner for our policymakers here in Nigeria.
Yes. Well, we appreciate you getting up so early. This is my first connection with Olivia, and it's just been amazing to connect with you. I'm really very appreciative of your work. Dr. Shrikandi, what are you looking forward to?
I am looking forward to seeing you, Sally. It's been a while, and Dr. Vidali as well. But really, endometriosis is, passion of mine. Really dedicated most of my career to it. So being at the Endo Summit is, highlight of the year always. Hearing the excellent speakers and being with the patient advocates, and it's always extremely rejuvenating. So that's probably the number one thing I'm looking forward to. But also, other than the non-invasive diagnostics for endo, as we've all alluded to, hearing more, getting updates on the neuroimmune aspect is always very interesting.
Yeah, it should be very cool. I think I am looking forward to you actually have data. Like people were like, but we can't prove any of this happens, that any of the musculoskeletal or the neuromuscular system is involved. And so you're going to present that data, which I know from my career that it is involved, but now we have proof. So I'm very excited to see that. But we're leaving out another very fun thing I would think you're excited for. Dr. Srikandi's group is our Flamingo sponsor. So they have made it so that our in-person attendees can all have a pool party on Saturday night and really kick back and relax. And I learned from being at Disney, actually, that a group of flamingos is called the Flamboyants. So we're going to be the Flamboyants, a yellow flamboyance, but we're going to be the Flamboyants, right?
That's great.
All right, tickets are on sale, www.theendometriosissummit.com. If you have questions, let's do this. How can people reach you, Dr. Srikhandi?
www.pelvicrehabilitation.com. It's our website, so pelvicrehabilitation.com. On Instagram would be at Dr. Ali or at Pelvic Rehabilitation.
Excellent. And Olivia, how can people reach you?
www.endosurvivors.org, email info@endosurvivors.org, social media, Instagram, Twitter, Endosurvivors, Facebook and LinkedIn, Endosurvivors International Foundation.
Yes, and let me tell you, to all the Americans out there, hit them up on Instagram to get the link to their organization, because sometimes the American system for some reason has a block, because I tried to go to your website and I want people to be able to go to it. So go through their link tree on their Instagram. Alex, how can people reach you?
InvisibleIconic.com, or on Instagram, it's at InvisibleIconic.
Wonderful. And Amanda, if people are looking for support, can they reach out to you?
Yeah, of course. I'm on Instagram at the Amanda Frucci, or I can be emailed at amanda.frucci@gmail.com. I'm happy to help, especially Canadians who are looking to navigate this broken system.
All right. Well, that's our goal. Like, by the way, when, we did Endo Summit Brazil, we're working on Endo Summit India, but our goal 1 year is to do Endo Summit Canada, but do it on our terms.
Let's do it. I'm down. I could help with that.
I have a little grouping there in the Quebec side that I would like to partner with. I heard that province is a little more open.
Yeah, I think so.
Open-minded, but we want to do it on our terms. And then we'll travel the world with all these Endo Summits. All right, next week, I'd love to tell you what the topic is, but I don't remember it. I think very much next week's topic is adhesions. And so we will see you back here, not with this panel, with a new panel Monday at 8 p.m. Good night, everybody.
Good night.
Thanks, Sally.